All right, so let's talk about iron balance today. So we already talked a little bit about this Monday when we talked about essentially equilibrium, the homeostasis of iron. So one of the things that we have to have is that balance. So when we lose iron, we have to reabsorb iron. Remember though, we need to always make sure that we don't absorb excess iron, because if it does, then it can lead to like hemochromatosis and some of these other disorders, okay? And remember, iron is also toxic to us, okay? If we get too much iron, it becomes a toxicity to us in our body. So daily absorption loss are usually small, okay, due to the recycling. We know we lose about 1% of our red blood cells per day, but our body's really efficient at recycling that particular iron. And so we don't really lose that much, okay? We actually only lose about 1 milligram per day through our urine, okay? Sweat, bile, and desquamation of cells. Okay, so let's talk about that. Do y'all know what desquamation means? Okay, in this case we're talking about, we haven't really talked about these types of cells yet. When we get into urinalysis, we're going to talk about these cells that are called squamous cells. You guys, well, we did this. 131, remember we did the cheek cell lab? Okay, those are squamous cells. So you remember how we talked about that iron's not just necessary for hemoglobin, but it's also necessary for like enzymes and those kind of things. So when you lose cells, you're also losing enzymes, because all of your cells have enzymes in them. So you're losing a little bit of iron through those enzymes when you lose cells in general. So just like the normal sloughing off, that's what it's called. It's called sloughing off the cells. In other words, they're being loosened from different linings of your body, okay? So that's what that means right there, all right, as we go, okay? And all the rest of it, you should know what we're talking about. All right, so let's move on. All right, so about 20 to 25 milliliters of RBCs are destroyed each day, okay? So this releases 20 to 25 milligrams of iron, but most of it is recycled, like we said before. So daily requirement for iron is about 1 milligram for us. And like if you're like me and you eat steak, you're getting plenty, because you only need to absorb 1 milligram, okay? No physiological route for excreting excess iron. And this is the problem. People that have hemochromatosis, this is why. It's because we don't have a natural way to get rid of iron, okay? Like every other thing in our body, just about chemistry-wise, we have a mechanism that gets rid of it naturally, okay? But iron is one that we don't. That's the reason people that have a error in their metabolism or an error in their body where they absorb too much iron, that's the reason it becomes toxic to them, or they start producing too many red cells, which is what hemochromatosis is. We'll talk about that later on, okay? So, for instance, water. Okay, I mean, I know this is really simple, but you can drink as much water as you want to a certain point, okay? Because your body has a way of getting rid of the water naturally, okay? You'll either sweat it out or you'll pee it out, right? But like iron, you don't have that. There's no way to get rid of it naturally, okay? Now, we can get rid of it. We can draw blood on you and do phlebotomies, or we can give you drugs that chelate iron. Does that make sense? There are some drugs that you can take in your body that will actually go into your body and grab iron and then take it out. And then it'll go out through either your poop or your urine with those chemicals, okay? But naturally, there's no way that we get rid of iron, excess iron, okay, as we go. So iron should always be recycled and reused. That's the reason we only absorb a certain amount each day, okay? All right, so let's talk about iron deficiency. Iron deficiency can occur if, okay, there is insufficient dietary intake of iron. This should make sense to you, all right? We're not eating enough iron. We can't replace that 1 milligram per day, all right? That's the problem in the Eastern worlds, okay? And I know we say that all the time, but it's because they eat lots of vegetables. They don't have access to the meats and stuff like we do here in the U.S. So they tend to have more iron deficiency anemias than we do in the Western civilization of the world, okay? Absorption is impaired. Okay. So we talked a little bit about acids in our GI tract. We talked about people taking antacids all the time. That can lead to iron deficiency. Also, if there's like a leukemia, or I'm sorry, not a leukemia, but like a really, really bad infection, sometimes people develop H. pylori. Y'all talk about H. pylori, Helicobacter pylori in micro. Causes lots of digestive issues, okay? And sometimes people that have, you know what dumping syndrome is? Have you ever heard that?
Heard it.
Irritable bowel syndrome. I know you heard that. IBS, man, there's like a commercial every other, on the TV, every other commercial for IBS nowadays. Those kind of things can lead to iron deficiency because the food doesn't have time to absorb. Does that make sense? Your body digests it, but it doesn't have time for those enterocytes to pull it in because it's going by so fast. Does that make sense to you? So that would be an absorption problem. Okay. Increased loss of iron through bleeding. So this is what happens to most females who are still having their menstrual cycles. Okay. Increased loss of iron through bleeding. Not only that, but things like GI bleeds, okay? Those kind of things, all right? Have I did my spiel on the GI bleeds with y'all guys yet? Okay? Did I get ugly? Did you hear me get ugly? Okay? Then you don't.
Let's hear it.
Let's go ahead and say it right now. Let's do it right here. This is a good spot, okay? Listen to me carefully. You don't bleed out your ass normally, okay? Does that make sense? All right? Y'all don't know how many times working in the lab for years, all right, my last 5 years before I became a teacher, all I did was blood bank. The last 5 years, all I did was blood bank. So I did blood transfusions for people all the time. You don't know how many times I went and looked at the orders for blood and their diagnosis was rectal bleeding, okay? And not only rectal bleeding, but it would be rectal bleeding for 2 months. Rectal bleeding for 2 weeks, okay? Listen, you don't bleed out your ass normally, okay? If you start bleeding out your butt, go to the doctor. Does that make sense? You know what Joseph's diagnosis would be? Bleeding from the butt for 2 minutes, okay? And I may go by helicopter. You know, so, you know, don't let that happen. Don't be embarrassed. It's not normal, okay? You know? I know you're going to say, well, some of us got hemorrhoids. It doesn't matter. That's not normal either. You know what I'm saying? Go see a doctor if there's problems in that area, okay? That makes sense? You should not become anemic because you're bleeding out your butt, okay? Not normal. Everybody with me? On that. Everybody with me. No bleeding out your butt. Okay, go to the doctor. Right? Okay. So then you won't have this problem. Then you won't lead to iron deficiency anemia because you're going to get that taken care of. You're going to let them run a light up your butt and do some cauterizing or something and fix it. Right? Okay. Iron overload can occur. Iron overload. Okay, so this means that we're absorbing way too much iron. Okay. Absorption abnormally increases. This is what happens with people that have hemochromatosis. Okay, they're absorbing way too much iron. Okay, individual receives multiple transfusions. Okay, patients that come in and they get 6 or 8 units, they can actually get iron overload. Okay, as they go. And then, of course, individual receives iron injections. You can actually give them too much iron. There's a fine line, and you have to be very careful when you're giving iron supplements, especially through IV, okay, or injections as you go. All right? Questions about that, guys? All right, now that everybody's awake and y'all will never have a butt bleed in your life, y'all go to the doctor quick, okay? All right. So, good chart right here, guys. You need to make sure you know these things right here. These 3 especially, okay? This one, be aware of, but I would always know this one, okay? Definitely watch some things that cause iron deficiency. These 3 things cause iron deficiency. Okay? And this one right here, we talked a little bit about Monday. I mentioned it, rapid growth. That's what's happening when, you remember I talked about babies. Sometimes you get physiological iron deficiency anemia. This can happen when they're babies, but it also can happen when they're teenagers, especially guys. Guys are, you know, we're really weird. You know, don't take us the wrong way. I know we're weird because we have that little Y chromosome. Makes us different. But we're also different because girls, you guys tend to be mature by the time you're about 15, 16 years old. Once you reach that age, you're as big as you're going to get. You're as tall as you're going to get, everything. Okay? So they stop. Y'all pretty much stop growing then. Okay? Guys are not like that. Guys can actually grow up to about 20 or 21. And so guys are really, really weird too because we literally can go to bed and wake up the next morning and be an inch taller. Okay? That's rapid growth. No joke. Okay? So what happens sometimes, teenage boys between like 15 and 18 can actually become iron deficient anemia just because of their growing so fast. Okay? Most of the time you don't see it because guys eat lots of meat. They're also going to eat lots of food during those times. Okay? I can always tell when Avery's is growing through a growth spurt. Because normally he's a grazer. You know, he'll eat a little bit and then, you know, 20 minutes later he's eating again, that kind of thing. But like if he'll sit down and eat, you know, an entire meal and then want dessert and all that kind of stuff, I usually know he's going to grow. He'll probably be taller tomorrow, you know, that kind of thing. He's reaching that age where, you know, you buy him pants today, 2 days, he's already outgrown.
How old is he?
He's 16.
Oh.
Yeah. And he's already about 6'2". So, you know, but he still continues growing. Huh? Not me. No, my wife is tall. My mother-in-law is 6 foot. And like her side, Amanda's side of the family, the Kings are like 6'4", 6'5".
I was a kin to that played football.
Well, I don't know. I don't know. I don't know. Probably not. All right. So iron requirements. So normally iron concentrations are constant, which is what we want. Humans are unable to excrete iron. We talked a little bit about that a while ago. Rate of absorption must equal loss. We talked about that. And then here's 3 factors that increase iron requirements. You do need to know these 3 factors. Okay? Does that make sense? Because come Monday, I'm going to ask you about them. Okay? Factors that increase iron requirements. The very first one, of course, is menstruation. You girls who are having menstruation, you definitely need more iron. Okay? So you need to take in a supplement if you're not. Okay? And I think I've been through this with you guys one time before. You know, if you're on birth control pills and you get to the end of your little cycle and those little brown pills that are at the end, most of y'all throw them away because, oh, they're just placebos. They're not nothing. They're just sugar pills. They're just to keep you on track and you're taking a pill each day. They're iron pills. Take them. They're brown for a reason because they're iron. Take them. Okay? Because what happens as soon as you take that last pill, you start your period, right? That company is making sure you have excess iron because they know you're about to go into your menstruation, okay? Another thing that requires more iron is pregnancy. You're not eating for yourself anymore, you're eating for 2. And that little parasite needs some iron also, okay? It's a little blood-sucking parasite. That's what they are by definition. And they will get the nutrients whether you do or not. Does that make sense? Okay? So when you don't want to gain but 4 pounds when you're pregnant, you're screwing yourself and the baby. Well, you're really not screwing the baby, you're screwing yourself more. Because the baby's going to get what it needs. It's going to suck you dry. Okay? So you have to make sure you're staying healthy to make sure it's healthy. Okay? So it's okay to gain a few pounds. Alright? Little advice for y'all that haven't had babies yet. You get pregnant, you gain some weight, breastfeed the kid. You'll lose the weight. They'll suck it right off of you. You know what I mean? So that's always a good thing. All right? Growth in infants and children. This is what we were talking about, that physiological anemia, iron deficiency anemia that babies can do. So a lot of times, if you'll read on like cereals for babies, okay, they're fortified with iron, okay. So a lot of the cereals and stuff, once they reach a certain age and start eating cereal, have iron in them. It's usually not enough, so a lot of times the doctor will also prescribe iron drops for them, okay. All right, questions about those three things? Very important, those three. You will see them on the test, again, I promise, okay? All right, so let's talk about lab assessment of iron. All right, so it requires multiple parameters. All right, one of the things that we do is we actually do an iron level, a serum iron level, okay? Total iron body capacity, we talked a little bit about. Calculation of the percent saturation of transferrin. Remember, that's transferrin. When we talk about percent saturation, we want to know how many of those transferrin molecules have 2 irons on them, okay? Because if they have 2, they're fully saturated, okay? It means they're full. They can only carry 2. And we do a serum ferritin level. We can do a serum transferrin receptor level, okay? This is not routinely done in the lab, okay? It's not routinely done. And then we can do an indirect measure by measuring zinc protoporphyrin ring, okay, or ZPP, all right? Now, this ZPP is also, we're going to talk about it when we talk about lead poisoning later on, okay? And the reason it is because iron is not the only thing that can carry oxygen, okay? So if we don't have iron, okay, in our body, remember how I talked about our body's really, really efficient a lot of times, or most of the time. So if iron is not available, which is a metal, right? If our body can find a metal that's similar in molecular structure, it will actually insert it into the heme molecule. And one of those metals is zinc. Okay? So instead of it putting iron 2, it'll actually put zinc 2 in there because they're very similar atom structure. Okay? And so oxygen can bind to it. Okay? So what you could do for a test, you could test the blood for the zinc level in those protoporphyrin rings. So that protoporphyrin 9 ring that's in the mitochondria, instead of inserting iron, it inserts zinc into it. So there's a test that we can do. It's an expensive test, not a really common test, but it is a good test. It's a very specific test for iron deficiency. Yes?
Does it get sent out to like a reference?
It does, yes. Most hospitals are not going to do this. This would be done at a reference lab, like LabCorp or Quest or somewhere like that. Okay?
Because it's expensive.
Because it's expensive and just not economical for a hospital lab to do it. And that's one of the things you guys will learn. So if I'm working in a hospital lab, or I'm the lab director at a hospital, and I have a doctor that says, well, hey, I need you to start doing ZPPs, okay? And you're going, because your business, you still want to make money. So you're going to say, well, okay, doc, I'll be glad to get that test in. How many are you going to order a month? Okay? Well, if he says 1, you're going to have to say, well, doc, I can't do that. There's no way that I can afford that. Because your reagent's going to cost you probably $500 for maybe 50 tests. You know what I mean? So that's a lot. That's a lot of money. Whereas reference labs, they may do 50 a day because they're getting from all over the area. Maybe the whole state, maybe the whole country even, depending on what your reference lab is. Okay? Now the doctor come in and said, well, I'm a hematology clinic. I work at, I'm a hematologist, or an oncologist or whatever. So I'm going to do about, 50 or 60 of these a month. Okay? Then you say, yes, sir. I have no problem getting that because you can make your money back. You may make a little or you may just break even, but you're also satisfying your doctor. Does that make sense to you guys? So that's one of the reasons why we say sometimes it's expensive is because that. It may not necessarily mean that the test is, $50,000, but it's expensive because it's cutting into your budget because you don't do enough of them. So you're going to end up wasting the reagents you buy if you don't do enough. Okay, does that make sense to you guys? I know that's kind of lab management, but you know it's what you need to know a little bit. Okay. All right, so let's talk about iron studies. So let's talk about those transferrin results. So transferrin is measured functionally as TIBC. Okay. So when we do our TIBC calculation, what we're really looking at is the amount of transferrin. Because what does TIB stand for? Total iron binding capacity, right? And we just said the only one that carries iron is what? Transferrin. So if we're doing TIBC, we're really doing transferrin. That's what we're really looking at, okay? So the maximum amount of iron able to be bound in serum, okay? Percent saturation is the amount of transferrin complex with iron, usually about 30%, okay? So that means we've got about 70% of transferrin that's free in our body, which is what it should be, okay? So what happens to what's going on, just logically, you guys know enough right now. Let's say that my transferrin level is 70 instead of 30. What's probably going on in my body?
I said that wrong.
Yeah, but you're on the right track. Not hyper, but
Hypo.
what are we making?
Hematoma.
Hemochromatosis. It could be hemochromatosis where we've got excess iron, we're absorbing too much iron, or what's another thing that could be happening?
Not releasing it or
No, think about our red cells.
excess.
What can happen to our red cells? Excess what? RBC what? Excess RBC, one more word. Starts with a D. What would make a red cell release its iron?
I don't know.
Destruction.
Oh.
So we have basically more hemolysis that is occurring in our body. So it could be intravascular or it could be extravascular. Either way, we're popping way too many red cells for a reason. Usually it's an intravascular. So let's say the patient has a transfusion reaction and they're popping those red cells that we've given them because they have an antibody that we didn't detect or something. Okay? So what's the transferrin level going to do? It's going to go up because we're going to have lots of iron being floating around in our plasma. And that transferrin is going to complex with it. So therefore our TIBC is going to go way up. Does that make sense? Because we've got lots of bound saturated iron or transferrin. Okay? All right. So quantity of storage iron accompanied by changes in serum iron and TIBC. So when storage iron is increased, serum iron increases, TIBC goes down. Okay? Which should make sense to you. If there's no iron available, then total iron binding capacity is going to go down because you don't have it floating around being bound to transferrin. Okay? Questions about that, guys? All right. When storage iron decreases or is absent, serum iron goes down, but TIBC goes up. Okay? So this is what we were talking about. So transferrin saturation of less than 16% is IDA. All right? So we said we should be at 30. If we go less than 16%, that means that we have IDA. Okay? Now, transferrin saturation greater than 55, then we have iron overload or hemochromatosis. Whichever one, just like what we just talked about. Okay? Does that make sense to you guys? Anybody it don't make sense to right now? We good? Okay, excellent. All right. Now, you're going to do iron studies every day in the lab. Okay? Every day you're going to look at this. You're going to see this stuff. Okay? So you got to know how to kind of correlate it to make sure things are going like they're supposed to on the machine. Okay? All right, let's talk about ferritin. Ferritin in general. So it is directly proportional to the amount of storage iron. Remember, ferritin is the storage form of iron. What did I say ferritin was? Monday. Starts with an M.
Metabolic.
Weird name. That's it. Micelle.
Oh, my.
Remember? Micelle. Ferritin is a micelle. Remember, ferritin is a protein that is surrounded by how many iron molecules? 4,500. Remember? Yes, ma'am.
Spell muscle.
Micelle. Dang, I spelled it the other day. I may not be able to spell it again. That it? That's it, because you helped me with, because I only had one L, didn't I? Monday. All right, so directly proportional, what?
Call it myself.
Mycel. That's fine, I don't care what you call it. As long as you know what I'm talking about. All right, so serum ferritin less than 12 micrograms per liter is depletion of iron stores, okay? And we're going to talk about this in just a little while if we get there today. We should get there. So IDA, there are 3 phases of IDA, okay? And we're going to talk about each phase. All right? So once, essentially when we really have IDA is when we have depleted all of our iron stores. That's when we really get iron deficiency anemia, okay? So there's 3 phases that we're going to talk about later on. So when the serum ferritin level gets less than 12, okay, then we know we have depleted all of our iron stores, and we're in IDA at that point, okay? Right? Serum ferritin levels greater than 1,000, we have iron overload. I see ferritin levels all the time greater than 1,500. That's how we report them at Riverview. If they're above range, we just call it 1,500. Greater than 1,500 micrograms per liter. Okay? So decreased ferritin is your first indicator of IDA. Alright? So here's the deal. Listen, we're going to talk about this in just a minute. I'll go into more detail about it. When you see microcytes and hypochromia on a CBC, we're already a year or more into iron deficiency. Does that make sense? Okay? Alright. So ferritin levels are going to begin decreasing immediately. Does that make sense? So like in phase 1 of IDA, is you're going to see ferritin levels. CBC is going to be normal. Okay? Because you still have iron, you're just starting to deplete them. So your cells are going to look normal, they're going to do whatever. Okay? But then eventually you're going to deplete them all the way. So when you get down to, what was it, 12? Was it less than 12 a while ago? Is that what it was, 12? So once you get to 12, you have not enough iron anymore to make normal red cells. So now what's going to happen to your red cells? We're going to make some, but they're going to be little tiny red cells because we don't have enough hemoglobin to put in them. Does that make sense? So your body's not going to waste its time making a normal size cell because there's not enough hemoglobin to fill it up. So it's going to make little tiny cells and then put as much hemoglobin in them as it can. Does that make sense? Okay? So by the time you reach the 12 ferritin level, then you're going to start seeing the results of the CBC. But it may take a year or more even to get to that point. Does that make sense?
Microcytes and what?
Hypochromia.
Oh, okay.
Yeah. I would talk about the morphology.
Yeah.
Okay? All right. One thing that's bad is ferritin is also an acute phase reactant. So we talked about a little bit about that with the electrophoresis. So it's in that alpha 2 region. So when you have an infection or any kind of an acute thing that happens to you just normally, ferritin levels drop. And so that's taking iron away also. Okay? So those are one of the things that we talked about, we're going to talk about when we talk about acute anemia of chronic disease. Okay? That's one of the reasons why it's considered an anemia is because that ferritin level is dropping. Okay? If you don't have any ferritin, you can't carry the iron. Okay? CBC. All right? So in IDA, normocytic normochromic cells are replaced by microcytic hypochromic cells. Okay? Not only do that, but you also have an increase in RDW. Why do you have an increase in RDW? Because then you have an increase in what? Anesiocytosis, which is the same thing as the increase in what? Different cell sizes. That's exactly right. Very good. Okay? So, because you're going to have some normochromic, normocytic, but you're going to see microcytes and hyperchromia also, okay? All right. So, what I'm going to say here, and I don't want you to think I'm being ugly to you, okay? At this point, you ought to understand that when you're doing a morphology, and I know you've only done a few, but I've tried to make it clear and plain to you guys as I can. If you're saying that you have 2+ microcytes, okay, there's still 2 more places, so that means there has to be either some normocytes or some macrocytes, right? Because if you had all microcytes, what would you say? 4+, right? But you only called 2+. So that means you had normal cells or macrocytes. Does that make sense? So if you've got normal cells plus 2+ microcytes, you also have onychiocytosis. And so it should be 2+ also.
Oh,
Does that make sense? Does that make sense,
Yeah.
Courtney? You just looked at me like, oh, damn. That makes sense. Huh? I got it. Did it click? Okay. Same way with like this, guys. If you say I've got 2+ target cells and I've got 1+ Burr cells and I've got 1+ dicryocytes, you better have freaking 2+ poikilocytosis, right? Because that's what those are. What you just called target cells, Burr cells, teardrop cells are poikilocytes. That's or prekilocytes, however you want to say it. Doesn't matter to me. Okay. You see what I'm saying? So those two things have to always correlate if you're going to put other things in there. Does that make sense? You also got to call that because that's what it means. That help a little bit? Okay, good. Excellent. Okay. Questions about that, guys? Good. Turn on some lights, man. I like it. I can see it. I love it. I love to see the lights come on to you guys. Okay? All right, CHR, which is basically the mean cellular hemoglobin of reticulocytes. Okay, so CHR, all right. Some of the newer instruments are doing this. It's part of the reticulocyte count that's on the machine. And essentially, it's basically looking at the size or the color of the cells and how much hemoglobin is there. So this measures functional availability of iron during hemoglobin synthesis. Why would we use reticulocytes? Why would we be concerned about reticulocytes? What is happening in a reticulocyte? Still.
They're immature.
Still a little bit immature, aren't they? So they're still making what? They still have RNA, so they're still making what? Hemoglobin. That's exactly right. Because remember we said the metarood stage, or the, let's see if I get it right, orthochromic normoblast. Is that the metarood? Yeah. Is that it? I think so. It's close. I think so. I think that's what it is. The metarubicyte, we said, had about 80% by the time it reaches that stage. 80% of it. So we still have to make 20 more before it becomes mature. Well, what's the cell in between that? The mature and the metarube is the reticulocyte, right? So it's got to still make at least 20% of the hemoglobin. So us being able to look at those cells kind of helps us determine the iron level, because it still has to have enough iron in those cells, in those reticulocytes, to be able to make hemoglobin. Does that make sense? So that's the reason we're looking at this. So this being decreased is an early indicator of iron-resistant or iron-restricted erythropoiesis. Okay, so if you don't have it high, it's not high enough. Okay, the level's not normal and it's low, then that means we don't have enough iron to continue to make that other 20% of hemoglobin that we need to make. Okay, before it becomes a mature erythrocyte. Does that make sense? Okay. All right, so let's talk about a hormone. Okay, there is a hormone. It's known as hepcidin. Okay, hepcidin. This one's important. You do need to know this. Okay, this is the major regulator of iron levels. Okay, all right. So we know we talked about a little bit in. Well, no, we hadn't really talked about that yet. Sorry, I forget. I was going to say, we talked about insulin, but we hadn't really talked about insulin, have we? So hepcidin is the primary hormone that regulates iron absorption and storage, okay? So hepcidin levels are going to impact iron levels also, okay? If you have low hepcidin, you're going to have low iron. Does that make sense? Increased hepcidin, you're going to have increased iron, okay? Because it is the regulator. So it's a potential to increase diagnostic accuracy of iron metabolism disorders, but testing is very, very expensive. So hepcidin levels are not what they are. Okay, listen to me closely. Guys are young. Every one of y'all in here are young. So me and Kim. Me and Kim, that's pretty much as far as we're probably going to go. But Kim, I do encourage you to go on at least get your MLS. Okay? Go get your bachelor's and do that at least. Okay? But like some of y'all are like 12. You know what I mean? Look at y'all, you're like 12. Okay? You still should be like walking around with a pacifier, some of y'all. Okay? So, my point is this, guys. There's a doctorate level now that you guys can do. You can go and be a doctorate of clinical laboratory science. Alright? So what does that mean? So that means that you're able to do like research, those kind of things. But one of the cool things that I would just love if it was me is you get to walk around with doctors every day and you get to say, hey, instead of us doing 15 iron studies, let's do a hepcidin level on this patient. Does that make sense? Mm-hmm. Because a lot of times iron and all this other stuff, they're diurnal. Y'all remember me using that word diurnal when we're talking about phlebotomy? Different times of the day. So like in the morning, iron levels are going to be one thing, and at night they're going to be lower. Usually. It's usually what happens. They're high in the morning, low at night. Okay? So depending on when the blood gets drawn, it may make the test look weird. Does that make sense? So instead of us spending money and wasting time shotgunning lab tests, I could say, hey, look, doc, this test is very, very specific to iron levels. If we order this and this is abnormal, then we know what's causing their iron to be abnormal. Does that make sense? That's what you would do, okay? And that's why you would save your hospital thousands of dollars, and they will love you. And the insurance company will love you. Does that make sense? Because right now, really and truly, insurance companies hate doctors. Especially doctors that are not real good doctors, because they will shotgun test. You know what I mean by shotgunning?
Order like a white.
Yeah, it means when you shoot something with a shotgun, it goes psh, right all over it, and you hit it, and you just hope you hit something, right? That's the way they do with lab tests a lot of time. And it's not their fault. It's really not. My nephew's a doctor. He's a pathologist now. Hey, let me brag a little bit. Got chosen to be the chief resident for next year. Going to be the chief head dog of it, pathology. So I understand. And I asked him one day, I said, Daniel, I said, look, son, I said, I've got a master's degree. I said, I don't know. I really don't know what medical school's like. I said, so tell me how medical school really is. And he said, well, the simplest thing I can tell you on Joseph, he says like this. He said, like when you go to Jacksonville in one semester, you go through a book. Like this semester, we're going to cover hematology, like the whole book of hematology. He said, we were going through like 7 books a month in each class. You know what I'm saying? And so like it was just bombarded with material that they had to learn, you know, and theory and those kind of things. So when I would start talking to him about tests, he didn't know what I was talking about, even though he's a doctor. And he's a lab doctor. Y'all realize that, right? The pathologist is the lab doctor. He's the one that's your boss. You know, he's your medical director in your laboratory. Okay? But he still didn't know all the tests. And the point is they don't know because they've never really been taught. Most of them now, used to, they have a book, now they've got an app. And they say, okay, well, I'm, iron deficiency anemia. Okay? And then it's going to say, well, order iron studies. You know what I'm saying? So they're going to order the ferritin, the transferritin, the TIBC, the UIBC, that kind of stuff. Okay? It's not going to say, well, if you order a hepcidin level, you would get more information than what you're doing ordering these other 5 tests. Does that make sense? That's where you guys would come in if you were that doctorate of clinical laboratory science. they can pick up the phone, and they will, because they want to get the result quickly too, because do they want their patients to stay in the hospital for 3, 4, 5, 6 days? No, they do not, because guess what? They don't want to go to the hospital to see them. You know, I'm being honest, they don't, okay? So if they can get you out and not have to see you for 6 months when you come back to their office, they're fine with that, I promise, okay? So when they find out that they have a person who is a doctorate and knows lab tests, they're going to pick up the phone and they're going to say, you know, hey Caleb, I need to know what's a specific test that I could order to get me a quick result, and tell me some information about iron deficiency anemia. And you can say, well, it's a little bit expensive, but you can do it in one test, okay? You not think 25 tests is expensive? Yes, it is, okay? And it may take them 24 hours or 48 hours to get the result, but because it has to be sent to a reference lab, but it's still going to be a better diagnostic tool than having to do all that other stuff. Does that make sense to you guys? So I encourage you guys to do that, okay? So hepcidin is a very, very important hormone, okay? All right, questions about anything? All right, so in your book, there's about 5 other ones that are regulators of iron. I don't really care if you know them. Is that bad? Okay. When you go do your MLS and your master's in clinical laboratory science and then eventually your doctorate, then you can learn those. But right now as an MLT, you don't really need to know them. Okay? Does that make sense? That's not being ugly, it's just helping you out. Okay? So, this is what you're going to see based off of the different things. Okay? So notice our IDA, you're going to have low MCV because what kind of cells do we have? Microcytes, right? So we definitely should see a low MCV, right? Serum iron levels are going to be low, right? Saturation is low. You can't be saturated if you don't have any iron, right? Okay. And then ferritin levels are going to be low because we don't have to have any ferritin because we have no iron to carry, correct? And then, of course, serum transferrin receptor is going to be increased because it's not being used. It's just hanging out on the cells waiting to be used to bind to transferrin. But because transferrin saturation is low, we have none. So there's no reason for us to worry. Okay? Does that make sense? Okay? And then these other ones you guys can kind of look at. This one we'll talk about in just a little bit, anemia of chronic disease. You see, usually it's either normal or low, the MCV. Low iron, low to normal saturation, normal to increased ferritin level on these patients. And then normal serum transferrin. And then in thalassemia, we'll talk about that later on. Thalassemia has nothing to do with iron. Okay? Now, the blood picture of thalassemia, especially thalassemia beta thalassemia major, looks like a really, really bad IDA. Okay? But it has nothing to do with iron at all. Thalassemias all have to do with the globin molecule more than the heme molecule. Okay? And then we'll talk about some of these other ones later on as we go. All right? Questions about any of that, guys? Kind of look at that chart, be familiar with it. All right? All right? So let's talk about IDA. How are we doing time-wise? 43 minutes. We're in good shape. Okay? All right. So, most common nutritional deficiency in the world. We talked about that earlier. Okay? Prevalent in grain-eating countries. Okay? If you eat lots of grains and no meat, okay? Now listen to me. What kind of meat do we have to have? Red meat. Because these people eat lots of fish, don't they? Most of these Asian countries and third world countries eat a lot of fish. If you don't believe me, go to like Israel. They eat like fish for breakfast. Promise, been there, done that. Pickled herring for breakfast. Okay? Salad. They eat lots of freaking salad. No meat. Okay? We actually did have like beef and lamb and that kind of stuff, but no pig. I like pig. I made nachos last night, guys. You know what my nachos had on it?
Bacon.
Had chips, cheese, okay, barbecue meat, pork, barbecue pork, bacon, and then smoked sausage on my nachos.
So
I like pig. I had like the boss hog nachos going on last night.
Do you check your own cholesterol up?
Yeah, I'm on cholesterol medicine. That's the reason I'm still eating the way I do. Medicine better do its job. Okay. So grain, major part of the diet. Hookworm infestations is endemic. Miss Cole's going to talk to you guys. There is a place in Alabama. I'm not going to give it away. You guys can look it up. To this day, 2022. Don't do it now, because she's going to give y'all an assignment for this.
Oh, okay.
I'm going to go ahead and tell you. There's a place in Alabama that today, 2022, is still endemic of hookworm infestations. Okay? 2 different types of hookworm. Let's go ahead and talk about that real quick. Hookworms. Alright, so you guys go learn this. Necator, I think that's how it's spelled. Americanus, I think that's right. This is the New World. Oops. Hookworm. Can't spell worm. Hookworm.
You're going so fast.
And then Encyclostoma, I think is how it is. Encyclostoma I think that's how it's at. I think that's how it's spelled. Okay? And this is known as the Old World hookworm. You guys are going to talk about this soon. Like are y'all doing parasite right now? Okay, so y'all doing protozoans right now though. Okay, so when y'all get to the helminths in the next little section, y'all start talking about the worms. And hookworm is one of those. Okay, but there is a county in Alabama, South Alabama, that basically still has endemic hookworm in their area, and a lot of it is because it's poor, bad sanitation in the area. Not a whole lot of people lives there. And that may be one of the main reasons, but there's still lots of hookworm in there. And it's a Necator americanus, Encyclostoma duodenum is the two. The Necator americanus, of course, is the New World, so it's the hookworm that's most common in America. Okay, and then you have the Old World, which would be what you would see in Europe and Asia and those kind of things, is Encyclostoma. What, girl?
I want to know
Okay.
if, I don't know the term for it, but the people who live in that county, are they sick by the hookworm, or have they?
Well, they have iron deficiency anemia. A lot of them. That's usually what you have. Most of them you have hookworm. You may not have like the diarrhea and that kind of stuff. The malnutrition is you have anemia, because hookworms suck blood. They hook on and they suck your blood. That's what they do. Hook onto your intestines. And so you're losing blood through the hookworms. Mm-hmm. Is that what you wanted to know?
Not really. But
Well, tell me again. Say it again. Let me do better.
I'll ask Ms. Cole. 'cause I
No,
don't know the
ask
term.
me.
I want to know. So the hook, there's a term or something that she was talking about that when they live with the parasites, you know,
The
if they
symbiosis.
have- yeah.
The symbiotic relationship.
Yeah.
They're parasites.
Well,
That
yeah,
is
but
the
do they
symbiote.
make them sick?
Well, yeah, they have iron deficiency anemia. So yes. But listen to me. Okay? And this is very important, because this is kind of biology, and you should really know this. Okay? Mutualism, commensalism, parasitism. Those are the three main symbiotic relations. You know what symbiotic means? It means we live together. We're close, right? So like mutualism, usually one benefits, the other one's not hurt or harmed. Okay? They're just mutual. And sometimes in mutualism, both are helped. Okay? For instance, like lichens. You know what a lichen is? Looks like a things growing on a tree, you know, or on your car, like a little feather-looking thing. Looks like a turkey tail.
Yeah.
That's a lichen. So that's actually a fungus and a bacteria growing together. And they're growing on that tree. They're both mutually benefiting each other. Okay? Commensalism is you're hooked to me, but you're not hurting you. Okay?
That's what I wanted.
Okay? Well, parasitism, anytime it's considered parasite, the parasite's benefiting and the host is being harmed. That's the definition of parasites. Does that make sense? So if you ever see anybody talk about parasites, the parasite itself is gaining and the host is decreasing, or is being harmed in some way. So like in this case, hookworm is getting blood and, flourishing, but people who have the hookworm are developing IDA. So IDA is not good, is it? So that hurts us. Does that make sense?
Yes.
Did I answer it then?
Yes.
I just didn't understand the question,
Yes.
I
got
guess.
it.
I'm sorry. All right, so decreased availability of dietary iron, chronic blood loss. These are also things that lead to IDA. Okay? Then anytime you have these things, you have an increased risk of developing IDA as we go. Okay? Questions about that? All right. So, IDA can occur due to increased demands for iron, poor diet, or malabsorption. Okay? So, blood loss, number one reason for IDA for most people, especially in the Western civilizations, is blood loss. So we talked about bleeding out your butthole, but you also bleed, you females, right? So it's still blood loss. It's normal, and it happens, but it is still blood loss. So 1 ml of blood loss is equivalent to about 0.5 milligrams of iron loss, okay? So that's big important for us. So chronic blood loss from like GI or GU tracts. Y'all know what GU means? Y'all know what GI means? Gastrointestinal. What's urinary? Yeah, urine. So like people that have chronic urinary tract infections, they can have. You can actually have like vaginal infections that are so bad they bleed. Those kind of things. Okay. Those kind of things can always, or almost always, cause IDA in males. When you have males that have IDA, it's usually GI or GU tract issues, okay? But males in here are not going to, because Mr. Thomas told y'all what? Bleed out your butt, go to the doctor, right? Listen to me. I'm telling you, I help you out, guys. All right? IDA can occur, blood loss, intravascular hemolysis. This occurs less often because we usually try to do a really, really good job with blood bank when we're doing transfusions to not give them the wrong blood type, okay? Signs of intravascular hemolysis, you'll have hemoglobin in the urine, okay? This is a new term right here, okay? Hemoglobinuria. Anytime you see nuria on the end, that's a suffix, right? Urea means in urine. Okay? So whatever your front part of your word is, hemoglobin in the urine is what it really means. Okay? Now, there's another term you guys are going to learn next semester, but I'm going to go ahead and give it to you. Hematuria. Hematuria literally means RBCs in the blood. Or in the urine. Sorry. RBCs. So the difference is when we look at a microscopic of somebody that has positive blood on their dipstick, okay, if we see red blood cells, intact red blood cells, we refer to it as hematuria. If we have a positive blood and no red cells, then we know it is hemoglobinuria. Okay? Because it's hemoglobin causing the reaction with the urine dipstick. Talk about that later on, I promise. You're going to have a whole summer of urine. All right? All right, so you can also lead to hemosideruria, which is basically you see little crystals of hemosiderin. Remember we talked about hemosiderin is a storage form of iron? Okay? When cells burst, that's usually what they have. So like the erythroblasts that are in the bone marrow, the iron that's stored in them is called hemosiderin. Does that make sense? So like if you have blood cells that are popping, okay, then what's released from those blood cells being popped is known as hemosiderin. And sometimes hemosiderin aggregates or crystallizes. It'll form big crystals. and you can actually see these. And you see these sometimes in people that have immune intravascular hemolysis, so like blood bank, transfusion reactions, and those kind of things. Okay. All right. Dietary deficiency, rare, most developed countries. We talked about that, with the exception of these three: infancy, pregnancy, and adolescence. And we've talked a lot about that today, so no reason to beat a dead horse, right? Okay. Malabsorption, uncommon cause of IDA, except in malabsorption syndromes. So like we talked about, irritable bowel syndrome, dumping syndromes, anything that interferes with that absorption. Gastrectomy. What's a gastrectomy? Not your intestines, stomach.
Oh.
Okay? So like gastric bypass surgeries. That's usually this one, but now you know they've got that lap band where they can go in and kind of pinch all part of your stomach, put that band around it. Same thing. It still would be very similar to gastrectomies. Okay? So people that have gastric bypass or have a more increased chance of getting IDA. That's the reason they have to keep those supplements going all the time. Okay? Atrophic gastritis. Okay? Basically, this is like stomach infections that cause the cells to shrink sometimes. Okay? So like those enterocytes get small. They atroph. Okay? Atrophy means to shrink. Okay? The term atrophy means to shrink. Okay? And then achlorohydria. What is that? Achlorohydria. What does A mean? Without. Chlorhydria. Chlorine, hydrogen, which would make us what? When you put hydrogen, water, and chlorine together, what do you get? Dehydration. Nope. What do you get chemically? You get HCl, which is what? Hydrochloric acid, which is what your stomach acid is. If y'all didn't know that, you should know that. But if you don't, that's okay. Nobody's asking you to take an anatomy class. Hydrochloric acid is what your stomach acid is. So achlorohydria is a decrease in stomach acid. Remember how we talked about that low pH is necessary to absorb iron. Okay? So if you don't have it, then you don't absorb iron. Right? Okay? Questions about that? All right? Hemodialysis. Okay? Anytime you have etology of iron or etology of anything, these are the mechanisms of how it happens. Okay? So we're talking about ways things can happen. Hemodialysis. Y'all know anybody on dialysis? A lot of people get kidney failure and have to go on dialysis. One of the big things about dialysis, it works good to be able to get the BUN level down, the blood urea nitrogen, and the creatinine levels down, which is essentially what we're wanting to do. Problem is the machines are not efficient and you lose blood. So most people that have hemodialysis have to turn around and have blood transfusions afterwards. A lot of times they'll get 2 units of blood after dialysis. Okay? I'm not saying always, but the majority of the time they do. Okay? So hemodialysis leads to iron deficiency because they're losing blood. Because their body's going to try to compensate. Even though you're controlling the blood loss, your body doesn't realize that. It just realizes that, hey, I'm losing blood. And so it kicks in erythropoiesis. Okay? And so therefore it starts making more red cells. Okay? Or trying to. So your iron stores can be depleted because of the blood loss, like we talked about before. Okay? 2 to 4-fold increase in erythropoiesis with R. This is recombinant. When you see this little R in front of it, most of the time it stands for recombinant. It means it's been created and given. Usually it's been created by some animal, okay, in a lab, and then it's being used for human. Okay? Most of your insulin today, all right, did we talk about this? Anybody diabetic in here? You said you were a type 2. Are you insulin though? You're not insulin dependent, right? So like a long time ago, insulin was, the only way you could get insulin was through humans. It was human insulin. So if you were using human insulin, what did you have an increase of getting? at that time in the 60s and 70s, not the 60s, 70s, hepatitis. That was the big one that we worried about, was hepatitis. But anyway, you were prone to get human problems, human viruses and these kind of things. Today, of course, HIV would be a problem. We definitely wouldn't use it today. So what they figured out they could do is they actually could put the gene for creating insulin in a bacteria. And then that bacteria makes insulin. So it's known as recombinant. Okay, we recombine the DNA, put it in something else, and it makes us what we need. Okay, it is. It's really cool. Okay, so EPO is that way. So a lot of times people who are on dialysis also have to get erythropoietin shots because their kidneys are responsible for making what? EPO, erythropoietin. So if their kidneys are shutting down, they're not doing what they're supposed to do. So they have to have this to be able to do this. Okay?
What's in the EPO shot?
EPO, it's the compound erythropoietin. It's a chemical.
Oh, okay.
So is
Not the erythropoiesis.
No, erythropoiesis is the process of making red cells. Yeah, this is erythropoietin, which is the protein that comes from our kidneys normally. But these people are having kidney problems, right? So they're not able to make their own EPO. So you have to give them some to help boost red cell production. Okay? So iron basically can't, when they get that big boost of EPO, they make a bunch of red cells so fast that their body can't absorb enough iron to compensate. So they lead to IDA. Okay? All right. All right, we're at an hour. I'm tired, so we're going to stop right there. Okay, so we'll stop right there. Pathophysiology. All right, so listen to me. Monday we will finish this. Okay, we're going to finish IDA. We're also going to finish porphyrias and all that stuff. We're going to try to finish this chapter Monday and be done with this, and we're going to move on to hemoglobinopathies.